Assalamu alaikum, Masikum Bakhair. Good evening. From here, I'm Man Jordan from the Farah Medical Campus. My name is Ibrahim Sbeih. I am a neurosurgeon and we are transmitting live to our international audience. This is a very famous painting called The Raft of Medusa by this French gentleman back in 1818. Medusa was a flagship of the French Navy, which sank opposite Mauritania. And these are the only people who survived, 15 people. There were more than that, but they ate the dead people so that they can survive. Our presentation today is pediatric tumor in the lateral ventricle, a pediatric case. So we are talking about the lateral ventricle, and this is the lateral ventricle within the skull. And in neurosurgical resident or practicing neurosurgeon must visualize what exactly is the ventricular system in relation to the cella, to the various parts of the brain. So the lateral ventricle is made of the anterior wall, the body of the trigone, occipital wall, and the temporal wall. Again, relationship of the lateral ventricle with the third ventricle at the corner of Monroe, and the equiductive cilius to the fourth ventricle. Here you would see two structures. The thalamus outside and inside is the head of the caudate nucleus. Here is again the same thing, ventricle, septum lucidum, and here is the mammillary body, and we have a tract between mammillary and thalamus, and then we have the fornix, the columns of the fornix, the body of the fornix, and the fimbria of the fornix. Ventricles are supplied by blood, of course, like any other structure in the brain. And we have the anterior choroidal artery coming directly from the carotid, and the two posterior choroidal artery coming from the posterior cerebral. One of them is medial to the other, so they are called medial posterior choroidal, lateral posterior choroidal, and of course the anterior choroidal. Anterior choroidal, against all beliefs, supply only the temporal horn, while the posterior choroidal supply most of the ventricular system. Again, if you ask any neurosurgical resident about this anatomy, they have no idea, no clue. If we look at the ventricles from the top, you will see the head of the caudate lying on top of the thalamus, like this, the extended capsule. So, head of caudate, thalamus. So thalamus is here in the choroidal fissure. Again, we have to imagine where the choroidal arteries are. This is the carotid artery, so the anterior choroidal comes this way to supply the temporal horn, while from the posterior cerebral we have the two medial and lateral choroidal arteries supplying the rest of the ventricular system. Another look here at the ventricles from above. The lateral ventricle here, the lateral ventricle there, right side, the anterior horn, the body. We come to the trigone, occipital horn, and then the temporal horn. And the choroid plexus, of course, is C-shaped in the choroid fissure. Again, the same picture, with more cutting to see or to show the temporal horn. And I challenge if there is any neurosurgical resident who would know what are the relations of the temporal horn to the brain. It's a mystery, they don't know. They just want to know about how to put screws in the cervical area. Again, here we have to remember one important anatomical feature, which is the optic radiation. Optic nerve, and then the chiasm, and then the tract, coming to the lateral geniculate body, giving the temporal lobe, and then the optic radiation going to the 17, 18, 19 in the occipital lobe. And this optic radiation is very much in relation to the ventricular system. It lies in the lateral wall and the inferior wall of the occipital horn, like this. Lateral wall and the inferior wall. So optic radiation is very important to remember when you are dealing with the ventricular system, the lateral ventricle. So this is a very beautiful bit about the optic radiations from Italy, how the optic radiation would look in various objects in various patients. Of course, this is tractography. Again, optic nerve, tract, Sbeih tract, coming to the lateral ventricular body, giving the temporal lobe, and then going around to the occipital area. So here you are, temporal, minus lobe, temporal, same thing here. Why am I mentioning this? Because it has very much relation to the surgery you will see. So this optic radiation will be displaced by the schema. This is intrinsic brain tumor. Because it is intrinsic, it will push the optic radiation, which is here, to be pushed medially, like this. So it will push it medially. While if you are inside the ventricle, the optic radiation will be pushed laterally. Again, you have to remember the relationship of the various tracts through tractography, whether it is motor or sensory or whatever association fibers. But here you can see with the tractography the optic radiation. If you look at the ventricles from front, coronal view, hemisphere, interhemispheric fissure, corpus callosum, anterior horn of the lateral ventricle is the third ventricle. And of course, the ventricle is very much related to the antenna capsule. And one of the questions I asked the neurosurgical residents in the exam is how far is the motor cortex or the antenna capsule from the foramen of Monroe? And the answer is less than 1 millimeter. Again, anterior view, we have to remember the choroidal artery, how it's supplying the temporal horn, and both the medial and lateral occipital arteries supplying the rest of the ventricles. Our topic for today is intraventricular meningiomas. Are these rare? Yes, they are. 1 to 2% of all meningiomas. What is the commonest meningioma in the brain? It is the parasagittal, it is the cortical. So this composes 1 or 2% of all meningiomas inside the ventricle. In the pediatric group, it's more. And how would you get meningioma inside the ventricle? Because meningioma does not arise from the dura, it arises from the arachnoid. And the arachnoid is part of the choroid plexus. Choroid plexus is inside the ventricle, so you will get intraventricular meningiomas. They attain big size, 2.5 usually at the time of admission or seeing the patient, but they can be as large as 8 centimeters. So, meningiomas are related to the choroid plexus, the arachnoid of the choroid plexus. And which is the commonest area for these meningiomas? Lateral ventricles, more than third ventricle, more than the fourth. So most of the tumors of meningiomas, they occur in the lateral ventricle. Which side? Left side more. Why? Nobody knows. Which part of the ventricle? Lateral ventricle, trigone, is the most common part. From the trigone, it goes to the posterior horn or the body or the temporal horn, and of course to the temporal. Anterior horn, 0. Why?
No
anterior horn, because there is no choroid plexus. And this study of 72 cases, not of meningiomas, but of ventricular tumors, 72 cases of ventricular tumors, it was common in the trigone. Again, in a study, 46 patients from Turkey, meningiomas constitute only 6 out of the 46. So it is not common, it is rare. In children, 54 cases of lateral ventricular tumors. Of course, you will have all the tumors, but to a lesser extent the meningiomas. So this is the list of these tumors. Subependymal gland astrocytoma is the commonest, meningioma is less. So whether in adults or in children, it is not a common tumor. but it is a very challenging tumor. Presentation, usually increased intracranial pressure. The commonest is headache. And I have a word about headache. In the Arab world, in this part of the world, in the Arab states, Muslim states, in Asia, we don't take care of the headaches. We deal with it as if it is nothing. The commonest thing that I hear from my patients, yes, I used to have headaches, which are normal headaches, relieved by simple analgesia. Remember, there is nothing called normal headache. If you have headache, there is a cause for it. Visual symptoms, because we are related to the visual tracts which we mentioned, related to the tenor capsule, gait disturbance because of the hydrocephalus, urinary because of the hydrocephalus. Seizures. Is it common to have seizures? When you have intraventricular, it is very common actually, up to 30%. And if you are having a tumor in the ventricle, in the dominant hemisphere, then you will have temporal or parietal manifestations. This is from a nifty book, the meningiomas. He looked at the authors who reported these cases, and he looked at how much the headache was there. It's very high percentage. So epilepsy, preoperative, postoperative. Usually postoperative epilepsy is more, and it could be generalized, it could be focal, it could be complex pressure. Is this the only manifestations of intracranial intraventricular meningiomas? No. This paper from Germany, 2007, about fatal hemorrhage from this meningioma. So meningioma was inside the head of the patient who did not recognize that he has a tumor, it bled and caused him to die. Meningiomas, one of the commonest tumors to have hemorrhage. Another paper from China, 2011, again about meningioma that has bled. And they looked into literature and found these authors reporting cases of meningioma that bled inside the ventricle. What about imaging? This is a very interesting case of mine. I think it summarizes all. You can get calcification in 50 to 90% of these tumors, telling that this patient is from Tafile, and he had this huge calcified meningioma. Maybe because it's from there. When you do angiogram, you are looking for the anterior choroidal and you are looking for the posterior choroidals. So the blood supply of these lesions usually comes from anterior or from anterior. When you are attacking them, you will not come through the blood supply itself. That's why it is a challenge. This is another paper about the feeding arteries. They enter the tumor anterior or anteroinferior. This is the tumor, and this is the anterior choroidal artery. If you put this picture for a 6th year neurosurgical resident in Jordan, he would not know anything about it. He would not know head or tail. Because we don't teach them about angiography. This is not for the neurosurgeons. مش إلنا بالضبط. So this is the anterior choroidal. Here, this is the posterior choroidal. You have to know exactly what they are, because if you want to do surgery for them, you have to see them. The other day we reported the orbit. People say, oh, orbit is not for neurosurgeon. It is for neurosurgeon. You will deal with the orbit every time you open the skull of the patient. What about the treatment? No doubt, treatment of choice is surgery. But look at this, mortality before the microscope was very high, because it is a challenging kind of surgery. It was reported first as a finding in 1854 by Shaw. Cushing did the first surgery for intraventricular tumor in 1916, and this is a monograph of Walter Dandy in 1933. All these patients died. If you want to do surgery, you have to avoid damage to the sensory tracts, to the optic radiation, and to the white matter interconnectivity. Well, what is this? Let's see. How would you approach the ventricle? Anterior, horn, body, trigone, occipital horn, temporal horn. So you reach each in a different way. anterior frontal, transcortical. According to the site, you will open. This is a very important piece of anatomy to remember. This is the ventricle. If you have a tumor here in the trigone, how would you approach it? Again, there's a beautiful paper about how to approach each part of the ventricles. Again, neurosurgical resident or neurosurgical practicing, you have to imagine the ventricles, where they are and how to reach them, and what are the relationships of these areas. Just in time. Again, people don't know this anatomy, especially when you open the skull, because your skull is important, small area. So if you open it here, you'll find a piece of brain, but which part of the brain? Who of the neurosurgical residents in Jordan or the Arab world or in Asia or developing country know the surface anatomy of these regions? They don't need to, because what he's interested is to put a sucker to suck the brain and treat the brain as if it is shaped. Sorry for the word. So you have to remember the Sbeih fissure, the ascending limb of the Sbeih fissure, this anatomy, the supraangular and the supramarginal and the angular gyri. Because when you open, you will open in this area, and vein of Labey is in your face. Damage this, patient will be hemiplegic, if not dead. Frontal lobe, parietal lobe, occipital lobe, temporal lobe, Sbeih fissure, ascending limb. This is the motor strip, this is sensory strip, and the sulcus in between, supramarginal angular gyrus. Where we open is here. This is shortest distance to the trigone, avoiding important areas. So you go through the brain, through the cortex to reach to the trigone. Either through the parietal lobe or the temporal lobe or the frontal lobe according to where the tumor is, or you go in between the hemispheres, the transcallosal. And when you do the parietal, your corticotomy should be away from the midline, it should avoid the central sulcus. So here you are, transcortical, transparietal, reaching to the trigone of the lateral ventricle. So this is tumor, meningioma, and you will go through this way. So it's called transcortical. And this is the optic radiation which we spoke about. So you have either to be a little bit low or a little bit above to avoid injury to the optic radiation. Parietal transcortical, this is the superior parietal, middle parietal, so you go this way, or you go through the temporal area through this way, or you go in between the hemispheres this way. The same thing, parietal, between the parietal P1 and P2 parietal. Here is transtemporal, T. T means middle gyrus, 3 is the inferior gyrus, so you go through middle gyrus to the trigone. Or as I said, they call interhemispheric. Some people are extravagant about their approach, they will go this way, trans-tentorial to the other side. I think this is too sophisticated and too complicated to accomplish. Michael McDermott is a very famous meningioma surgeon. He's a meningioma man in San Francisco, and he published this paper about intraventricular meningiomas of different sizes. And he again stressed the important points of the optic radiation. Optic radiation is lateral and inferior to the trigone and to the occipital core. So you have to be careful about it. This is the interhemispheric, this is the right side, here is the midline. You go in between the hemispheres, you go and do cortical incision in the corpus callosum and enter into the ventricular system. Like this. So you are going interhemispheric. Engelbert Knoss from Vienna, Alexander Bergampi from Switzerland and Germany. They published this, and they wrote this chapter of meningioma lateral vertical and left field meningioma book, and they again state the approaches to reach to the triangle. Knoss, of course, is the man who discovered the relationship of the pituitary to the cavernous sinus. The lines, so-called lines of Engelbert Knoss. Again, this paper, as I said, it is the contralateral transfer sign. I don't believe in this extravaganza because it is not needed. From China. You can use the endoscope, the endoscope, yes. This paper from China, again, they went into ventricular cysts. They are good for cysts, no doubt about that. Mark Swedan from Lebanon, who lives in the States, he's a famous man in endoscopy. Again, he used the endoscope extensively to remove such lesions like choroid cyst. Here's the formula of Monroe, this is the choroid plexus, this is the cyst. So endoscopy is one of the armamentarium that we use in our surgery. And this paper by Charlotte is a female lady with Axel Bernitsky from Mainz in Germany, and they published this paper about surgery with the use of the endoscope. What about radiosurgery? Imagine people using radiosurgery for intraventricular tumor. Let's see what these people, the giants of meningioma, what would they say? Not Ibrahim Sbeih, the giants of meningiomas. I call myself a meningioma man, but these are giants. Lemardermo, Tusan al-Mufti, Engelbert Knoss, Alexander Bertalanffy, radiosurgery is only for those who are not candidates for surgery. Period. No matter what they say, you don't use radiosurgery up front. No matter what paper they produce, no matter what jargon they would use. Paper from Japan. Look at this. The title is very interesting. Presumed intraventricular meningioma, because they don't know what it is. Without a biopsy, without anything. This is the tumor. Let's give some embolization. It will get shrink, and then we'll hit it with gamma knife. Absurd kind of thinking. I don't know how these people think. What about this remaining in the head of the patient 5-7 years and then turn malignant? Gamma knife radiosurgery for intraventricular meningioma. Again, it is laughable for me. Oh, this is the tumor. This is the radiation. Oh, here it is. 3 years after. So what? What have you done? This is the mockery war. Gamma knife for superficially located meningiomas. Why would you give gamma knife for superficially located? Gamma knife is a good tool. It was made to treat small lesions that are very deep, that cannot be reached by surgery. Why in the hell would you go for these kind of tumors? Yesterday, I came across this, and I had to share it with you. Gamma knife being given to 5 tumors. 5 tumors at the same session.
Big tumors at that.
Bilateral. And each tumor was treated as single lesion for the same amount of money. So 5 lesions.
Contraindicated.
Absolutely contraindicated. Absolutely. It defeats the object of radiosurgery.
لا ربما أخذ 55,000 إذا كل واحد
لا راح أخذ 28.
55,000.
Why would you treat? Why would you treat this? Why? Tell me. Why would you treat? Why would you treat this?
عشان ما يكبرش.
Yes. Look. Personal series of mine. I published this paper a long time ago, 2009, with my residents, Amir and Muhammad and Omar. They are very good people and they have gone very far in their discipline. We published this in the Pediatric Journal of Neurosurgery, and this was about this Jordanian family with subpendimergian cellular society. I think we have presented this here. This is the father, this is the mother. Father is okay, mother is a carrier, and these are the 3 children, male children. The elder boy, the middle boy, the other boy, all with these CDAP kind of tumors. So my series 85 to 2018 of intraventricular meningiomas. I'm not talking about intraventricular tumors, I'm talking about intraventricular meningiomas. If I want to mention the intraventricular tumors, I have about 162 third ventricular tumors, and I have more than 350 of lateral ventricular tumors. But if we take just the meningiomas, I have 20 cases. It says the frequency is to get one case per year if you have a high volume, which means that in 33 years, I should be getting maximally 20 or 15. And these are common more in females than males, and again, left side was more. Some of these cases which I came across, different kinds of meningiomas, these are actual cases of mine. Now let's come to the case for tonight. I think we're doing well with that time. This is a boy, 33-year-old. He came to the hospital in the middle of the night, unconscious, Glasgow coma scale 8, fixed dilated pupil. No movement at all on the left side. What would you do? Let's see his images quickly. Look at this. This is a dying person. This boy, his leg is in his grave. He is going to die, except for God's will and wish. Look at the shifts. Look at the pressure on the midbrain. Look at this. Very vague tumor. It's very ugly. It's not well defined. It is hazy. But look at the shift it's causing and the hydrocephalus it is causing. What's the treatment? Shunt. No. If you shunt him, he will die on the spot. If you even put external drain, you have to put it very carefully. So the only thing that you can do is surgery. No shunts, no external drain, just go for it. Why? Because if you put external drain here, you will cause more shift. So you go for the kill, for the tumor. Look at this. Midline is far on the other side. But again, this is very hazy, ugly tumor. And of course the hydrocephalus. Of course, we intubated him and sent him for the MRI. He was not known to have any complaints. Suddenly, he just collapsed at home because of his hydrocephalus and the brain tumor inside. So intubated, ventilated, sent to the MRI, and we got these pictures. Look at this. Look at this. Tiny capsule is gone. The whole brainstem with the brain and bones shifted. Okay, so what's the differential diagnosis? Of course, we did not come across that boy at 1 o'clock in the morning and say, oh, what's the differential diagnosis? Whatever his differential diagnosis, he needs surgery. But for you now, sitting here at ease, what is the differential diagnosis of this case? Again, people think this is exaggeration. This is the minimum acceptable for anybody practicing anything in relation to the neurology, neurosurgery. You have to have a list of differential diagnoses. I put them as cysts, or encephalic cysts, arachnoid cysts, choroid fissure cysts. People don't know about choroid fissure cysts, they don't exist. Ependymal cyst from the ependymum, a neuroglial cyst, and this is all these patients are patients in mind, except this one, the Zellweger. I know Zellweger, the female actress, exactly. I love the lady. She's beautiful and she's very well acting. But Zellweger, I should remember it, is kind of leukodystrophy. Choroplexus cyst, epidermoid cyst, colloid cyst, This is one of the largest coronary cysts in the world, and he's one of my patients. And he came with one shunt. Disease of the Arab world, disease of the underdeveloped world. I think everybody should be ashamed of himself to put a shunt, unless it is very mandatory. And don't give us excuses that you are alone at night, nobody's there. There are so many million of solutions to do it. But because it is something that you do and take money for, please stop doing it. A good shunt is no shunt. Ependymoma, came one patient of mine. Subependymoma, subependymoma astrocytoma, which we mentioned. They see that. Choroid plexus papilloma, I actually presented this case here in this room. Whether it is papilloma or atypical or even cancers. So not all the choroid plexus are benign, some of them are malignant. Look at this, pilocytic astrocytoma, huge. Again, one patient of mine, we could excise it completely because it is pilocytic. There's no radiation, no chemotherapy for that. Wait. Okay, so pilocytic astrocytoma, grade 2 or highly malignant. Oligodendroglioma, they love this area. What is this? This is chordoid glioma. This is ganglioglioma, and this is ganglioblastoma. As if these pathologies don't exist, so we don't think about it. Brain, we think of glioma, astrocytoma, medulloblasoma, 3 kind of pathologies. Pituitary adenoma. There are more pathologies there. Abdominal pain, appendix or ovarian cyst. No. So many pathologies, but you don't want to know about them. Neurocytoma, one patient of mine from Sudan. Germinoma, I presented this case to you the other day. PNET, we'll present it next time. Metastasis inside ventricle, yes. Teratoma. And this is lymphoma. Again, I presented this some time ago. I will revisit that again. We forget about lymphomas. This is a thalamic hemorrhage. And look at this. Who would think that this is an aneurysm? Hydatid cyst, neurocysticercosis, lipoma, tuberculoma. They are there, but you don't want to think about them because that will demand that you go and study and read. And people get their certificate to kill and they don't even read a word about it. Once they pass the exam, they don't read. They are masters of the art and they are just there to kill people. Yes, good.
So, the reason why we say it's absurd to have treated a presumed lesion with radiosurgery or embolization followed by radiosurgery is that you're burying the evidence. And when the patient dies, he or he died with brain tumor, which would have been expected, and the patient dies with the evidence buried with him. So these are actual cases. And look at the difference in the approach had you known what was going on. And the only way to have known what was going on would have been to do surgery or the test before surgery to avoid surgery if not necessary. Now, the cysts I'm not going to dwell upon because the treatment is surgical and they're predominantly seen in this age group. However, ependymoma is treated radically differently after surgery. In pediatrics, we try to avoid radiotherapy as much as possible in pediatrics protocols. In adults, these patients would have gotten radiotherapy after surgery. meningioma as well, and then a platinum-based chemotherapy, which is integral in the treatment. Gliomas generally, with all grades, including a grade 4, those would be treated with optimal surgery and alkylator-based chemotherapy and radiotherapy, depending upon the age group of the patient you're dealing with. Germinoma, which is even with the presentation with brain metastasis, is treated with curative intent, even if it's metastatic from the germ cell, from the testis or the ovaries. But even if they present with metastasis, they're treated with curative intent, and if they present in the CNS as primary CNS germ cell tumor, that's also treated with curative intent. And the treatment after surgery would be chemotherapy, cisplatin-based, with radiotherapy, depending upon the age group that you're talking about. Lymphoma in this age group would necessitate ruling out systemic leukemia or lymphoma with a second CNS involvement, and the patients in that case would still be treated with curative intent. Metastases are probably less of an issue in this age group, but frequently missed, as are intraventricular lymphoma. Now, these are actually cases where treatment would have been radically different. Now, the myriad of infections, including TB, and we've forgotten that we are living in a part of the world that is endemic for TB. And you miss TB with CNS involvement, the patient simply dies. And all of these would have been masqueraded, or the evidence would have been completely obliterated by radiosurgery. Be that following embolization or prior to embolization. And these are actual cases. This is not a mental exercise of what this could have been. We continue having this on a weekly basis, and these mistakes continue to happen on a daily basis.
So, it's the middle of the night, maybe 2 o'clock in the morning, and this is when I open the door after hyperventilation, after mannitol and steroids, and head up, and still the brain is bulging out. And the only thing to do is to go for it. Some people will stop and blame the anesthetist. Oh, I have brain edema, this is the anesthetist's fault. It is your fault. It is not the anesthetist's fault. You have to do something about it, and something to do. There is a cyst, and I want to go for it quickly so that I will get some of the fluid out. This way, the only way to save this patient's life. So I allow this fluid, dark yellowish fluid, to come out, and then I come across the tumor. Again, here is the low, this is below, this is above, this is anterior, this is posterior. So we are in the superior temporal area at the junction with the parietal lobe at the marginal and supramarginal angular gyri. So the tumor here looks okay. I was happy. Oh, there is a good plane of cleavage. It looked ugly. To me, this is not good. And how would you get a frozen section 3 o'clock in the morning in a private hospital? No way. Because by the time the histopathologists would come, the technician would come, God knows. That if anybody answers the phone, start to
In public, I mean, best hospitals.
Of course.
But we did froze the section.
No. I'm not saying that
This
it's
is it.
done. I'm saying the banality that prevails.
So as if there is a good plane of cleavage, but then here you see this white matter here, the line with the tumor. I was starting to get disheartened, feeling that this is nasty, but I continued. I will do my best to take as much as I can. The idea of biopsy and here we decompress the brain, the fluid is out, and we have taken a small piece, let's send them for radiation. This is a crime. When are we going to stop these crimes in the Arab world? A crime that happens every day, maybe 10 times a day, in a country like Jordan or in Syria or Darabur or in the Middle East or in Asian countries. This is against the teaching. And I think the surgeon who sent the patient for radiotherapy after biopsy is as criminal as the radiotherapist who treated this case. don't accept these cases. Say, send back to the surgeon, do your surgery properly. So here, started to feel maybe we are not winning here. Sadly, look, when we cut it with the scissors, it's hard. Something funny about it. What the hell is this? I don't know. So we have inside the triangle of the intraventricular, anterior, posterior, temporal, top of the head. So the temporal horn should be this way, occipital horn should be this way. So I tried to remove as much as I could from this tube. And just move forward with this. Here at this point, this is the ependym of the ventricle. I start to feel, well, we are losing the metal and not being able to take the rest of the tumor out. Let's do as much as we can and see what the histology is. So this is the triangle, this is the temporal horn, here it is.
ساعة خلصت العملية حكيم هاي
I can't remember, but it took about so much. This is important. This is feeding artery coming from the posterior choroidal artery. It's a very important step. And I will show you what is the value of this later on. So the brain is slack. Let's see. I will not stop at the histology here, I will proceed and then discuss it later. Of course, we'll put an external drain for nurses, male and female nurses. External drain is not a drain. It is a neurosurgical hell of a job to do. Don't treat the external drain as a drain. It is something special. If you put it down, patient OCSF will come down and he will die. So this is the initial post-operative MRI. The following day, the following morning, is a good CSF collection here, but still the tumor is there. So this was the initial, and this is how we were left. And then started the battle of what to do. I will discuss later. So let's go here for the histology. We waited after the surgery for about 3 months because there was so many speculations and discussions. In Jordan, we have specimen of Dr. Hassan Anab from Jordan Hospital. He reported it as papillary meningioma. Dr. Salah Jitawi reported it as either astroblastoma or ependymoma or papillary meningioma. Dr. Rahman Zahir and Dr. Shaka and Dr. Haddad from King Hussein Cancer Center, and I invited the 3 of them. I don't know if any of them is here. They reported meningioma grade 3. Dr. Abidat, Fatma Abidat, and Sbeih from King Abdullah reported it as ependymoma, astroblastoma. What would you do with this? Okay, so let's see what our histology is. Dr. Hassan.
Actually, this case was done in 2005, if I remember. April. So, a long time ago. And again, unfortunately, we don't have the slides in the block. By Jordanian law, we are obliged to keep the slides in the block for 10 years. But the reports will be kept indefinitely because they can be filed electronically and they don't take much space. So unfortunately, we don't have the histology or the pictures. But luckily, I write usually good microscopic descriptions. And this is good because, as you can see, it was a highly cellular tumor, and it had diverse morphology, and it appeared to be arising from meninges overlying the brain. There were areas of brain invasion and seedlings along the meninges. The tumor cells were slightly variable in size. They were condensed around the blood vessels forming pseudopapillae, and there were occasional mitotic figures. The background was very vascular, with splendid hemangioperocytoma-like blood vessels, and there were degenerative changes with excessive hemosiderin. Actually, probably this is what caused this dark color on surgery. And there was prominent lymphoplasmatic infiltrate also. So the differential diagnosis by histology was atypical meningioma, ependymoblastoma, vascular tumor, even I thought about the yolk sac tumor. And I did some immune markers. The tumor cells were strongly positive for epithelial membrane antigen, and it showed a membranous pattern of staining, which is typical of meningiomas. They were negative for GFAP, which excludes ependymoma, actually, because ependymoma are very strong. Ependymomas might be positive for epithelial membrane antigen, but they have a very characteristic dot-like positivity, not unlike here where we have a prominent membranous staining pattern. CD34 was negative also, as well as alpha-fetoprotein, because I thought at that time about yolk sac tumor, where they were all negative. So this provides, for me, favored meningioma. Other diagnoses are unlikely. So I call it a typical meningioma or papillary meningioma. And here I think I made a mistake. I think I was at that time following the WHO order classification, because in 2000, they put the typical papillary meningioma into the malignant category, which is grade 3, and King Hussein Cancer Center, they were right about it. Now, this is not from the same case, but just to show you, it has a papillary configuration. If you can go to the other view, you can see this is very cellular, and the cells are centered around the blood vessels. Actually, these are not true papillae. They are what we call perivascular pseudopapillae. Probably they take this configuration because the tumor is proliferating rapidly and it exceeds its blood supply. So only the cells around the blood vessel will survive and produce this pattern. And this is also a very prominent pseudopapillae, and you can see that this could be also confused with for example, choroid plexus tumor, because it is papillary as well.
Dr. Salah Jita, are you around?
Unfortunately, his mother died. So.
Yeah, he phoned me actually. Dr. Jitawi from Jitawi lab, he put testoblastoma, papillary ependymoma, papillary meningioma. This is from King Hussein Cancer Center. Dr. Rafat Shakra, Dr. Haddad, Dr. Sbeih, they called it papillary meningioma grade 3. From King Abdullah, Dr. Fatima Abidat and Dr. Smail Mataqa, they reported this after consultation with Edinburgh in UK, and Dr. Colin Smith and Dr. Bill Joseph and James Ironside. They said this is peanut. So, why not ask people outside? So, James Ironside and Colin Smith from Edinburgh called it peanut. Werner Paulus from Münster, Germany, called it meningioma grade 3. Tarek Tihan from University College of San Francisco, he consulted with two friends, Peter Berger and Bernard Schreiter. They called it meningioma or choroid plexus tumor. And the family members took it to Canada and Australia and it came back as meningioma. If you were in my place, what would you do?
So you basically covered all our differential
That was the
diagnoses.
differential diagnosis. So I was left with this. Let's see what they have wrote. This is Tihan saying, this is a malignant tumor, this is mesenchymal, and maybe it is meningioma, or maybe it's a choroid plexus tumor. However, Paulus also said here that we sent these slides to Tarek Tihan in San Francisco. He raised the possibility of choroid plexus tumor. Again, here he's speaking about it is not very typical of meningioma. Peter Berger said, I think it would be of great value to complete the surgery. So this is one man who said, Dr. Sbeih, please proceed with the surgery because it looks like an meningioma. And I took this into heart and I operated again. This is a child, 3 years old. Don't give him radiotherapy because you are not sure. So here you are. This is the cavity of the ventricular triangle and this is the tumor. Now, putting in mind that this could be meningioma, I wanted to remove it completely. No matter what time it takes. This boy, future is in my hands.
So when you stopped the first time around, Professor Sbeih, what were you thinking?
Malignant, extreme malignant.
Yeah, I know that you were considering malignancy, but I mean, what
Histology?
made you stop as opposed to
I
complete?
could not find a good plan of cleavage
Okay.
in the medial part or the internal capsules. I didn't want to, already he's hemiplegic. But look at this is a tumor. I could really go around it. I could catch it. Not like the previous time. So, good plan of cleavage here. Maybe because I cut the blood supply the first time that I got this. Which is a well-known fact that when you cut the blood supply, they tend to get compact. So I really could find a good plane of cleavage. Stop and sit for the therapy? No. If this is my child, I want some honest surgeon to do the shot for me. If we think of this all the time we treat patients, we'll stop doing the crimes we do. Look at this. Look at plane of cleavage. You can tell where the tumor plays the ependymon of the ventricle. So I'm not going to damage anything. I proceeded around the tumor. Oh, this is the tumor. What is the point? I'm cutting it here. It is more of solid rather than friable. Again, I think this cutting the blood supply first time helped me out. So this is the tumor.
هاي العملية بعد الأولى بكم حكيت؟
3 months. 3 months of agony on what to do.
Did it increase its size during this 3 months?
No, I will show it to you now.
أنا طلعت برا العملية الأولى كانت بايوبسي.
No, radical excision, but we've left a big piece also. Simply because we could not reach to the plane of the cleavage immediately where the internal capsule is. But here, after cutting the blood supply first time, I can really go around it. Very good plane of cleavage. So I'll stop because eventually we'll remove the whole tumor. Okay. So, this is immediate post-op, the following day. No tumor. No tumor. 2 years later, no chemotherapy, no radiotherapy, no shunt. This is a boy. Young age. 3 years later. Of course, the ventricle will remain dilated because there was a huge tumor there. 4 years later. These are actual pictures. 10 years later. Look at this. I found him actually 3 days ago and asked him to come to my clinic. Yes. Here he is. This is after the second surgery. And I'm looking at him, he's looking at me. I asked him, I want to repeat this. So I look at you, you look at me. To me, no money in the world can give me the satisfaction of this.
This is not a course of malignant tumor.
No. I think it was meningioma grade 2, atypical, according to the new classification, which is not malignant. And I think we made the good choice of going again, remove it, and did not give the patient any Again, I see you. This is before we started. This is when we
After
went
this.
for second surgery, and this is the last. With this, I finish and I thank you. Any questions or comments, please? Dr. Asil. Asil of Sbeih.
Did you send another histopathology, the second surgery?
Yes, it's capillary meningioma grade 2. Yes, it's not malignant.
Actually, by default, capillary grade is grade 3 now.
I know. So we're talking about grade 2.
Typical grade 2.
والله حكينا
Yes.
احكي لنا شو كان البوست اوبراتيف كورس بعد الفيرست سيرجري، يعني بين الفيرست والسكند
Absolutely well. Good.
يعني صحي الولاء
صحيح. No,
بعد قديش صحي؟
صحيح immediately.
بعد العملية
Yes,
مباشرة
absolutely.
فيش لا هيمiplegia ولا
No. His was just compressive. His pupil was compressive, so we just pulled him out.
يعني صحيته ثاني يوم؟
So, of course, don't leave a patient on a ventilator. We mentioned this many times. Okay.
When you excise the coil plexus, will it proliferate again or not?
The tumor was arising from the arachnoid of the choroid plexus. But the choroid plexus will not deal with it, it will just take the attachment. And it will not make any difference at all, neither in the CSF secretion or the circulation.
I'm wondering if, you know, in 2005, you didn't use KI67 proliferative index that much. You didn't, it was not even probably,
Absolutely, it was not used.
was not used. But did you do it on the, did they do it on any case
No.
or no? It would have been helpful to know actually KI67.
Professor Sbeih, أول شيء يعطيك العافية. Did you notice after this long follow-up any change in the IQ of Sbeih? You,
Actually, yes, he's not brilliant at school, but he is average.
yeah.
Because I think he held his hydrocephalus for some time. And when we went deeply into the matter, he was slow at school before.
Oh.
But again, slow at school. in
He's still
Jordan
alive.
is-
بصير نائب
So,
بصير نائب
before, Isa.
Well, I want to say, if I was the resident of call at that day
No, you are not.
and came to me with this huge lesion, cystic lesion, I can place EVD. Can we put intra
cystic drainage.
cystic drain and this?
You can. Now this is the solution of the
Just,
the week.
ريزيدنت دكتور
Solution
عملناها
of the week.
مش ريزيدنت، اذا افرض طبيب التخدير ما خدرتكيش الحاله بالليل وانت بمستشفى وزاره صحه، يعني مين بده يمون على دكتور تخدير يفتح كرينيته من الساعه 2 بالليل بوزاره الصحه ولا بالجيش؟
This is another
Ah.
another story. Victor.
Dr. Ibrahim, thank you very much. I have no words to describe your works. But Saturday before last, my first cousin died in one of the health ministry hospital from appendix, and he was 58. They told the family he's fit and well, 58 and no medication, and he's old.
ما لهاش انه كثير
Same cousin,
الله يرحمه.
2002, and New Year's Eve night, same cousin, he had the pituitary hemorrhage and apoptosis. He was unconscious at King Abdullah Hospital. When I've asked him to transfer him to Jordan Hospital for defibrillating, they said he's not transferable. Glucose scale is 5. He's needed there. I've asked Dr. Ibrahim at that time, can we go and do the surgery there? We went there, something like 6 o'clock. Arrived there at 8. We worked. He worked. I anesthetized him. He worked, and he was.
Survive.
He did survive, but he went till Saturday before last. He died from an appendix. What I want to say, always it takes two to do either to kill or to do such a good work.
100%.
Our job is extremely difficult because sometimes we deal with fantastic surgeons. The joy, as you said, the thrill when you see such a patient go? Most difficult thing in anesthetist's life to anesthetize somebody who's unconscious.
Yes.
Because actually that's our job, to make people unconscious. But to make unconscious unconscious